Go ahead and get started with the presentation. So welcome everyone one more time to the special Social Determinants of Health SDOH Academy Innovation Webinar Series. This is our session number 2, and we are excited for you guys to join us. Next slide, please. All right, so good afternoon, everyone. Again, my name is Hanso Ibarra. I am a health strategy specialist with MHP Salud. And today I'm accompanied by my fellow member of the SDOH Academy, Esli Reyes. You can go ahead and wave, Esli. She is the Health Education Products Manager at National Center of Farm Worker Health. Next slide, please. So today's agenda, we are going to complete our introductions and review some housekeeping. We are going to go ahead and talk about the SDOH and innovations. We are going to share the SDOH Academy resources. After that, we will go ahead and start and conduct our panel presentation along with the discussion. We will follow that up with some question and answer, some Q&A, and then we'll finish off with our evaluation, our survey, and some closing remarks. Next slide, please. All right, so now with the housekeeping, your mic will be muted as you log into the session. This is done so to avoid background noise that could prevent some of you all from hearing what is being said. If you have a question, go ahead and type it into the Q&A window, and we will address it during our Q&A session. This session will last approximately 60 minutes and will be recorded. The recording and slides will be shared at the SDOHacademy.com website in a few business days. I would like to go ahead and repeat that again. The recording and the slides will be shared in a few days from now on our SDOH Academy website. So if you're curious, if you hear something and you're like, hey, you know what, I want to get a hold of that, visit our website and you should be able to find the slides and the presentation. If you experience any technical difficulties throughout this presentation, feel free to reach out to someone from the NCMLP team through our chat box, and they will go ahead and assist you with that. Next slide, please. So who is the SDOH Academy? So the SDOH Academy, the Social Determinants of Health Academy, is a HRSA-funded work group of national training and technical assistant partners, faculty, who work together to develop training and technical assistant opportunities to help staff from health centers, health center control networks, and primary care associations develop, implement, and sustain social determinants of health interventions in their clinics and communities. It was funded back in 2017. The Social Determinants of Health Academy created a set of foundational trainings available to all health centers and runs yearly topical and population-based learning collaboratives to encourage peer learning and strengthen institutions' SDOH practices. To learn more about the SDOH Academy, feel free to visit our website. Next slide, please. So here we have all the different logos from the organizations that make up the SDOH Academy. In total, I believe we are more than 18. So that is quite the amount of organizations for us to present. So if you're interested in learning more about any of the organizations that you see here that make up the SDOH Academy, feel free to visit our website. Next slide, please. All right, so at this moment, we would like to go ahead and take this moment to acknowledge our founder, HRSA. This project would not have been available without their support. Next slide, please. All right, so one of the Healthy People's 2030's 5 overreaching goals is specifically related to social determinants of health, which was to create social, physical, economic environments that promote attaining the full potential for health and well-being for all. So social determinants of health, your SDOH, are conditions in the environment where people are born, they live, they learn, they work, they play, they worship, and they age that affect a wide range of health, functioning, and quality of life outcomes and risks. They can be broken down into 5 different categories. And you see those categories in your left-hand side in the circle. We have economic stability, which is the access to well-paying jobs. We have education access and quality, which is access to good schools. Healthcare access and quality, accessing affordable and good healthcare. We also have neighborhood and built environment. Does the neighborhood have plumbing? What is the violence rate for the neighborhood? Is there loud noises in the neighborhood? Pollution? And we also have social and community context. Is this community experiencing any discrimination? If you go ahead and see on your right-hand side, the breakdown of the individual, it shows us that up to 50% of our healthcare can be traced back to our zip code. So to where we live, where we work, where our families are raised. And then we go ahead and see that 20% is accounted through health services. So this adds up to about 70% of health is determined by the environment and the healthcare services that are available to us. This leaves that our own health behavior accounts for 30% of our own health. So to say that our health is completely an outcome out of our decision is not true, because as the visual shows you here, about 70% of what makes our health is from where we live and the type of services available in your community. So where we live, where we learn, where we work, where we play has a great impact in our health and health outcomes. We must address upstream inequalities through place-based cross-sectoral collaboration. Our speaker from session number 1 educated us on using the term societal drivers of health instead of using social determinants of health. He stressed that using this other term, societal drivers of health, encourages or influences people to think about the type of impact that your environment has and puts it more emphasis on where you live and where you work, and not so much on your own decisions, on pulling yourself by your own bootstraps. We also spoke about policy and how policy can impact social determinants of health. If you missed our first webinar, I suggest that you go back and you give it a listen. There was a lot of good information shared in there. Next slide, please. All right. Innovation is a new solution to an unmet need that has the ability to transform services, process, and systems to accelerate impact, as well as address SDOH factors to improve the health in their community. Health centers and primary care associations have continued to develop and scale life-saving and life-improving innovations to improve the health and well-being of their communities. And as I mentioned, we have our webinar number 1 up. So if you missed it, feel free to go ahead and take a look at it. Next slide, please. And in this slide, we go ahead and share the different work that the SDOH Academy has conducted throughout the past 3 years. In 2021, we conducted a webinar series. Back in 2022, we decided to do things a little differently, and we organized a competition. So we opened up for other health centers to submit to us their innovative ways that they are promoting SDOH factors in their community in gathering that data. And for 2023, we decided to go ahead and compile all that information together. So if you're interested, curious, and learning more about what we've done, as I keep on saying, feel free to go into our website and you'll learn more about the work that has been done in the previous years. And with that, next slide, please. We've come to the start of our content. So I'll go ahead and pass it over to my coworker, to my fellow member, Esli.
Thank you so much, Hansel. Again, my name is Esli Reyes, and it is a delight to be here and be able to present our awesome panelists who will be sharing their expertise and knowledge with us today. So we can go to the next slide. Today we have Dr. Andrea Caracostis, who is the Chief Executive Officer at Hope Clinic. She has dedicated her life working to provide equal access to care for all. She's a medical doctor with a master's in public health, biostatistics, and epidemiology from Texas A&M, and has 25 years of experience in healthcare. Since 2007, she has led Hope Clinic as the Chief Executive Director. Hope Clinic is a federally qualified health center providing care to the large multicultural community in Southwest Houston. Under her leadership, Hope Clinic has grown from having 5 employees and a $700,000 budget to a large corporation employing over 200 staff and a $30 million budget. Hope Clinic is nationally recognized as a quality and innovation leader by the Bureau of Primary Care. She is board member at various local and national healthcare organizations, including Harris Health, Texas Association of Community Health Center, Asian American and Pacific Islander Community Health Center Organization, and Susan G. Komen Medical Board. She has been voted as the top 20 CEOs in Houston in 2019 and most admired CEO in 2021. With such an impressive bio, we welcome you today, Dr. Andrea Caracostis. If you can wave so we can see who you are. Awesome. Next, we have Palak Jalan, who is the Chief Population Health Officer at Access Health Community Health Centers, located in Fort Bend and Waller counties in the greater Houston area. Palak holds a bachelor's degree in dental medicine from India and a Master of Public Health degree from the School of Public Health, University of Texas. She is responsible for strategic partnerships, care coordination, expansion, development, and making the operations more community-centered. She is instrumental in leading teams in population health and value-based care efforts, along convening and participating in multiple community collaboratives to conduct needs assessments, community focus groups, and prioritizing efforts around COVID-19 testing and vaccine. She has a passion for digital transformation and works with stakeholders to determine the most scalable solutions. Her efforts around the lack of sidewalks have led to private foundation funding a city of a multi-year, multi-million sidewalk project. Her expertise lies in strategic integration of social determinants of health into clinical practice and leading teams to achieve health and quality improvement goals. We are thankful to count with your experience and knowledge, and we welcome you today here, Palak. And last but not least, we have Olivia Riutta, the Director of a Special Population from Montana Primary Care Association. She directs the Cover Montana program. She leads MPCA's work to identify and impact patient-level social needs, facilitates the Montana Health Justice Partnership. We're glad to have your representation here today, and we look forward to learning more about the work that you all do. And without further ado, I will pass it on to Dr. Caracostis so she can give us an overview of the work Hope Clinic is doing around SDOH. Next slide, please.
Well, thank you so much, and for the beautiful introduction. I am really humbled and happy to be here. QHCs have been always an inspiration to me in terms of all the work they do, and I really worked my whole career with federally qualified health centers, and so I love to see us evolve, looking beyond our clinic walls. Next slide, please. So a little bit, very briefly, about Hope Clinic, and just to let you know that we are relatively young at QHC. We have 5 locations. However, our unique expertise lies in the amount of in the languages we provide care in. We serve people that speak over 60 different languages, and we've delivered babies from over 9 different countries. Next slide. This is a little graph that looks that shows the diversity of the patients that we serve, and I think this is really critical because it brings not only highlights the diversity of Houston, but also the fact that we're a globalized country and a globalized city, and every conflict that happens in the world eventually affects us locally. Next slide. So just a few words about Houston. Houston is the 4th most populated city in the country, and the most diverse city as well. And Hope Clinic provides 180,000 patient visits a year. And to highlight how many of our patients actually walk to our clinic, about 12% live in a walkable distance to us. Thank you. Next slide. So this is a little bit of just description of what you mentioned before. We have about 200 staff, 5 locations, and we are in charge of 28,000 patient lives and have a budget of 30 million. Next slide. So we're really here to talk about SDOH, and this slide, I know it's very busy, but I really wanted to start this presentation with a roadmap. We have talked a lot about the social determinants of health and how they impact our families, and we live that day to day, so I don't want to bore you with telling you all the challenges our populations face. However, some of the innovation that we've been part of has to do with really trying to create a system to define and measure those challenges and bring them into some numbers that we can later measure. So some of our efforts have been trying to figure out. Our first strategy has been around food insecurity and transportation. And some of the things that we have done are trying to collect data about sidewalks and also about where people get their food. And in that process, we've done walkability studies, which are opportunities for us to walk with our staff, our board members, and some of our patients around the service areas of the clinic and map out what are the physical challenges that the patients have to come to the clinic. This is Houston, temperatures get really hot. So if you don't have shaded areas to walk through, patients are likely not to come to their visits if they, or, get walk to school or even go to the grocery store. Same with the integrity of the sidewalks, and document all those things, have interventions, and then measure the changes. Same with the foodscape studies. We have forms that we have used over the years to map where the restaurants are, how much time people spend there, what type of food they consume, and then imagine opportunities to develop systems of change that will allow the community to spend more time around, as a family, around the food areas, whether putting a park or in close proximity to a shopping center that has several restaurants, helping the restaurant owners get opportunities to change the structure of their business to be able to welcome more outdoor activity in the restaurants. And so those are some of the examples. Of course, then we engage in really understanding what type of change would the community welcome, and what resources do we have to be able to ascertain that change. Later, we have been able to implement some of our strategies and immediately measure some of the change, and then spread and create conversations about possibilities of those long-term changes being creating newer opportunities for the community. So our end goal certainly is not only to address those social determinants of health from the convenience of our four walls or through referrals, but actually create an environment of community change that will have a long-term strategic impact in that community. Next slide. Okay, so after that, you heard a little bit about our roadmap, and so I just want to talk a little bit about some of the activities. And can we go to the next slide first, and then we'll come back to this one, that we have created really to address some of the social determinants of health that our patients have and that we all face. One of them being food insecurity. Certainly, we have a program called Bite of Hope, and it has four main components to it that include certainly a food for prescription program, a food pharmacy, where our patients can get a prescription for the different food they may need. We have a van that comes every month to the clinic, and they can use their coupons to walk through the mobile grocery store and pick up the food they need for that month. In addition to that, we have a chef, and the chef does the cooking demonstrations while the van is here to make sure that the people who are getting the vegetables and other foods that they get here know how to prepare them. A lot of times we and we have been guilty of that. We give our patients just a box of food of whatever the food bank has, and we run the risk of them not being ethnic foods that this community eats, and then not understanding how to cook it. And I can tell you one occasion we delivered food to our community, and it had a box of broccoli stems. So if you're not Asian, you're not likely to eat broccoli stems on your regular diet. So you really need someone to coach you on how to cook them and entice you to be open to consuming that type of vegetable. The Bite of Hope program also has a outreach program to the middle schools in 2 of our school districts, where we serve around 600 children through culinary cooking classes. The cooking classes include all the foods and vegetables for the families who are attending that cooking class. And the idea is certainly to expose the children to different foods and vegetables early on, but it's also an opportunity to engage the families in cooking. So we have face-to-face classes at the school, but we also have online classes. And those online classes, the family receives the box and we watch the families cook in the comfort of their own home. And it's a partnership between the parents and the child, really to create that environment of adventure in cooking and the exposure not only to the children, but also to the adults. The other 2 components of Bite of Hope are a culinary institute, where we actually are starting to train cooks and chefs through an 8-week course that not only teaches them about the how to chop vegetables and store them and prepare food, but also surrounds them with health information about their own health, about the impact of the food on other people, and nutritional opportunities to cook more mindfully. And the last component of our Bite of Hope program is a leadership, we call small business leadership group, where small businesses are able to join our trainings for 8 weeks. And in those 8 weeks, they learn, of course, again, collective purchasing, e-commerce, hygiene, and the chef works with them to perfect their menu, and teaching them how to replace sugars, how to manage portion control, how to cook with less starches, use alternative starches, as well as manage their books, manage their health, get insurance, really making sure that the business succeeds. Later, we do all the marketing for them, and we include them in our list of restaurants that the providers can recommend to their patients if we're to get healthy food. The next program is RV Free Houston. Again, talking about liver health and about our hepatitis B and C programs, and our perinatal care and baby script and perinatal program, which includes a app which is called Baby Scripts. And through this app, our moms can receive education. We turned into this app during COVID, when we couldn't have prenatal classes at the clinic anymore. And this app is able to serves as a remote monitoring device as well. The moms at risk may get a controlled blood pressure cuff, and we can monitor their blood pressure within the portal of this system. But the blood pressure can also be integrated with our EMR. We can also monitor what the moms like, what they are watching. For example, if they're watching more about child development or breastfeeding, and we can feed them additional information through this app, including challenges that they may have with food or with transportation, and really understand what are our moms really worried about, and then address those needs individually. Now we can go back at 1 slide, please. So this is our some pictures of our culinary program, and you can see that how much the kids are having fun, cooking, and I think they're making spring rolls in this pictures. But there's many ways to address the social determinants of health, and certainly referrals are very important, and we do use several of our systems to close our loop referrals, such as Unite Us and Leading Reach. But our purpose really is to go upstream and make sure that we're not just doing a referral to address the immediate need of our patients, but also building a resilient community so that we can address those things. And I think that's my last slide, Leslie.
Thank you so much. Great presentation. And next, if we can move to Access Health slide to learn more about it, and all yours, Palak.
Awesome. Well, thank you, everybody. Such great to hear from Andrea and all the amazing work that Hope Clinic is doing. Very excited to see all of you all on the call. I'll start with a little bit about Access Health, but then delve deep into our two major topics for today, which is SDOH and innovation. Next slide, please. Okay. Lots of words in the slide because I heard that eventually everybody will get a PDF of the slide deck. So we decided to have a little bit more that everybody can see. We're an FQHC, private nonprofit organization, have been in the community for a very, very long period of time since 1975. It's very interesting to me, how we started as a VIC clinic, then eventually became, a little bit of a larger clinic, then a lookalike, and then now an FQHC for the last, more than a decade or so. Currently, we have about 5 clinics and 11 WIC sites across 5 different counties in the greater Houston, Fort Bend, and Waller County areas. We're sort of like in a unique spot, like a lot of other organizations, where our population is about to touch 1 million in some time. And then in one of our counties, that means there is a lot of growth happening, and we're going to be trying to be there to provide the best possible care. We provide integrated care services. So all these beautiful icons that you see, those are all the services that we provide under the same roof and in an integrated fashion. Next slide, please. So this is the footprint. For folks that are familiar with Texas or Houston, hopefully this helps with the loops and loops and loops. But folks that are not, this is sort of that it is. And I always say that, we could almost be like halfway to Houston and Austin, and there's still like an Access Health clinic there. So that talks to the disparities and the health needs of different communities that we see in some ways are very, very similar, but in some ways are very diverse because of geographic location. Next slide, please. Okay, now coming to the fun social determinants of health conversation. Years ago, we got a grant from a local foundation, Episcopal Health Foundation, enhancing some of the work that we do as a health home, which is if you come to us, we provide these integrated care services in a good fashion. Eventually, we are a certified patient-centered medical home. So if you put patient at the center of all our services, and then CQA looks at our quality metrics, and we're grateful to have been awarded that recognition. When we look at, being a community-centered health home, it truly means that all the social determinants of health that have been discussed so far, we're not just, acknowledging them, but working actively towards addressing them in a downstream, upstream, and midstream manner through different changes. So next slide. So when I start at the start, what do we do? There is so much technology and innovation right now out there in the world that we can learn and grow from it. The biggest thing that we realized is we need to ask folks where they are at and where they stand. We, a couple of years ago, when we started doing this social needs screener or social drivers of health survey or non-medical drivers of health, however we specify it, of course, providers know and we know the needs. And we realize that patients want to talk about it themselves rather than having somebody hovering over them trying to ask that question is what worked best in our setting. So we did a comparative analysis and realized this is what's working. We looked at all the screeners out there, Accountable Health Communities, Prepare, other, We Care, other things that were out there for peer-reviewed screeners. We got a community of folks to work together to drill down on what are the questions that we truly want to ask. Where do we have the solutions, and where is the gap to be able to support that? I know this slide is pretty small, so you can't truly see the questionnaire, but it's getting those insights into factors that are influencing health and well-being, and that allows us to target or enhance based on the data we receive. So we see about 20 to 25,000 patients a year. And in that, almost 90% folks are filling out the screener every time they visit, which is almost once a quarter. When we got them to fill it out, we realized, where the needs and the priorities lie, like food insecurity, or, what does that look like? Legal needs, and then the association of that with medical health. And I know we'll talk about it a little bit in the future. So this truly provides us and has provided us with almost a baseline to gauge some of the work we're doing and where we're improving and where there are still gaps. Next slide, please. So three-pronged approach, right, that we're trying to think about. We want to reduce the barriers to healthcare or health overall. We want to empower our patients to achieve better health outcomes. And by addressing the things that we see. So you saw the screener, it gets entered into our EHR. From our EHR, it creates tasking for our community health workers to address these needs. And they have mapped out partnerships and referrals that we have for those needs. It also flags the providers because it's a part of their medical chart if they want to help have that conversation with the patient about something specific that they're seeing, and if they want to change their care plan accordingly, knowing where the patient is at. So it's a very, very powerful approach from both ends to think about it from the provider perspective and the information that it's providing them. Sometimes they know a lot more from the patient, or sometimes they just don't. And then at the community health perspective, we are actively then working on addressing how it's going on. And we do that in a variety of ways. So of course, helping with transportation, with our local United Way 211, we have something called the Integrated Client Journey. We are doing fruit and vegetable prescriptions across our multiple clinical sites. When we first started, we realized that almost 60 to 70% of all prescriptions are being redeemed. So that doubled the amount of people that were going to that food pantry. So let's say the food pantry was taking 500 people day one, and then we started the food prescription program. For client choice, they can go and select what fresh fruits and vegetables for 15 pounds they want to get. Now they're seeing 1,000 folks versus 500 folks. So that also shows the importance of that data for other needs and services in the community. So we were able to expand quite a lot of that. And now we've expanded our food prescription program to multiple sites, but it starts with the provider because the provider is writing the prescription, and then the community health team is taking it over. COVID taught us a lot, including that, it's not always feasible to walk into a food pantry and be with folks when you need to maybe isolate or distance or don't feel comfortable. So we have a partnership with DoorDash and United Way that it delivers food to people's home, healthy food, fresh fruits and vegetables to people's home in a certain radius, again, twice a month that it does that. So our patients have greatly benefited from that as well. And then medical legal program. We saw that legal needs one of the highest, small things like minor traffic violations, bigger things like guardianship issues or things about immigration or anything else. They're such a big stressor. We've heard about, a patient coming into the clinic with asthma, And the root cause wasn't just, that the patient is not taking the medication. The root cause was the mold in the house. So with a medical legal partnership, you can address the mold in the house through working with the landlord tenant issues. So we do this in a variety of ways. These are specific programs that we have, but then we know that, we won't have enough resources to address everything all at once. So housing, for example, we know is like a huge gap. So for that, our piece is more on advocacy and how can we rely on advocacy to say, this is a huge gap in our county, in our city, in our community, and how can we work on that in a better form or format. So sometimes the sell is not just, we're doing this, it's the right thing to do, but it's also making sure that we are able to communicate those needs to the policy and stakeholders to think of it as a health ecosystem. And we do have our partnership with Uber for Uber Health, and we work with local transit so folks are not missing out on appointments or major needs that are happening. I'm seeing some comments come through Q&A, and I think we'll address that in Q&A, right? Okay, perfect. Thank you. If we can move on to the next slide, please. So one of the last things I want to talk about is the health navigation platform. So I shared how we do the screener. It goes into our EHR, which is step 2. And then step 3 is a bunch of programs that you saw, but there's not a program for everything or, a specific process. So we have a system that is connected to our EHR. We built it ground up. We saw so many softwares out in the country. We read researches and reports on how they're working, what's the best way to address it, but truly nothing was fitting our needs. We wanted something that we could use, adapt, and build on. So we worked with some developers to create the software called the Health Navigation Platform. And as you can see in the graphic, we have a QR code and code. So what that does is, as soon as the patient leaves in the next 2 days, they receive a notification from a provider. We asked, who is the person you trust the most on your health journey? And, I thought it would be sports person, I love Serena Williams or I love JJ Watt. And those are the people that I would trust to get some message from. But we realized most patients told us it's their healthcare providers. So patients receive a video saying over a text or an email, whatever the preferred form of communication is, in a language that's comfortable to them. We have 2 major languages, English and Spanish, that our patients speak. So it's in both languages, depending on who they are and the kind of provider they see. So it's it's targeted towards the patient or the patient's family if it's a pediatric patient. I'll just slow down a little bit. But on that note, the video says, welcome, you're getting this notification because we really care about your health journey. You told us a few things in your visit that you probably need some support with. So be on the lookout for some notifications that are coming through. So if through our screener, patient was screening, let's say for all social needs, this video would go out, but our CHW would see on the platform as a task, and our AmeriCorps members as well, to go ahead and address that with the patient. So do an in-person visit or a telehealth visit with them, explain to them that they would be sent resources directly for their needs, and then follow up with them for their support. But if it's 1 or 2 or 3 things and we can allow technology to drive it, then we would do that. Community health workers are a vital part of our workforce, but we just don't have enough of them and we don't have enough reimbursement. There was a research, and if we were to have that many CHWs to address each need, which I hope at some point we get to, there's just not enough resources to double our workforce. So we have to rely on technology and build it up in a manner that it can aid the use of that human interaction that we're having with providers, with CHWs, with other clinical care teams. So they get that notification, then they get another notification as to how they can use the system. It's fairly easy. And it sends them direct referral. So it tells them okay, this is the closest food pantry to you. You can go here. They'll be waiting on you. And then that pantry, if it's in person, has a kiosk where they can scan their code or they can type in their code and get the service. So we know it's closed loop. If the pantry is very sophisticated and has a caseworker, we can exchange notes between our teams. But if it's not the case, it's a volunteer-run, small utility support or a clothing support organization, then too, they it's not a lot of burden on the CBOs or community-based organizations. We're able to help and support it in the same way. So to say it all, it's a process to truly scale up an intervention when we're thinking of more than like 20, 25,000 for some folks, even more than those patients, to address needs in a way where we know those resources. We have MOUs with those community partners, and we know like those warm handoffs will be served and not wait to know like, oh, did the patient actually get some help or not? So that's the piece. So we piloted it last year. We worked with a few organizations. We have a few hundred patients that have already used the system. They've been very, very excited and useful as to how they've used it. And in those higher risk stratified methods, we've done the most like in-person communication. So it's an interconnected web. It's not one thing, but this thing is closed loop. It allows us to analyze data. It provides CBOs as well, the community-based organizations, data to understand how they are helping meet the needs of patients, clients, etc. And it's an infrastructure that's long-lasting. We can make updates and changes at our end that also creates updates at their end. So it's been hard. We've created something from the ground up, but we know like we want to do this long-term, and it's a long-term strategy to address the social needs versus, like getting a Band-Aid that may not have worked for us the way we are as a system. And I appreciate it. I think if we move on to the next slide. That's all. I know we'll get to talk as a part of the panel, but here's my information. And thank you all.
Thank you so much. So now we will hear from Olivia and the work of the project.
Great. Thanks all. Olivia, Riutta, I use she, her pronouns, and I'm with the Montana Primary Care Association. So we're going to go from kind of a health center, right? Primary care associations work directly with health centers, to kind of perspective from somebody working at the state level. So this is Montana. We look different than Texas in some ways. If you put the bottom right corner of the state of Montana over Washington, D.C., the top left corner is over Chicago. And so we're going to talk about kind of a project we're working on to address social needs in a much bigger space than I think the two great examples that came before. So we are really talking about the Montana Health Justice Partnership. It is a medical legal partnership project that includes the Primary Care Association, who I work for, 7 of our health centers, and Montana Legal Services Association, which is our only legal aid agency in the state. Makes it really clear who you should be partnering with. And what I think is interesting about this project and makes it innovative is that we run it as one project. There's one screener. You can get a copy of that screener, and we can make sure you have a link to that, and that we collect the same data points. And so we really, while there are multiple partners, the Primary Care Association is at the table to kind of help facilitate that. So because we do not have the capacity in Montana to be running and doing oversight for all of these, for 7 separate medical legal partnership projects. As your states, as is true in your states, I am sure that there is an access to justice issue, particularly for folks who are at or below 125% of poverty. And so the little legal things are the actual offices of Montana Legal Services, and all of the little medical homes we have 7 health centers who have multiple sites that are a member. Next slide, please. I will just say that I wanted to put this slide in here. If you haven't seen HRSA's Advancing Health Center Excellence kind of framework, I think it's fabulous. I think that this framework came out after we started our project in 2017. But I think, I hope that this is the future of where some of this funding, HRSA funding changes will go, but where we center health equity and really include patient level social needs kind of in this team-based approach to addressing patient health needs. So next slide, please. So I think the other thing that makes our project innovative and unique is the way that we have approached funding. There's some words on here. The thing that matters is in the beginning, we got a grant. We didn't get a planning grant. We got a pilot grant. Why plan when you can just start sprinting? But what we realized pretty quickly was that if we wanted, that there was consistency if we were able to fund the project as a partnership, wherein everybody puts money each year into the project so that we are able to have access to this incredible legal team through Montana Legal Services. That is different than a lot of how other MLPs are funded. But it is the way that we could make ours work and not, I think, consistently and actually build with some confidence the program going forward. Next slide, please. And you can see those amounts in there. So we care about data, we care about how we are screening and what those screenings are resulting in. You can see this is our data from the dawn of time of the Montana Health Justice Partnership. What you can see is that during the project was both very important during COVID and also very challenging with what we like to call sometimes screening fatigue, especially during the throes of COVID. It was both so important to patients and also really challenging to kind of keep screening for health harming legal need and social needs at the forefront for care teams in our member health centers. And so that's something we're still working on, I think, as we kind of continue to move out of COVID in Montana. Next slide, please. And just one note, we're a giant state, right? We have always had a model where we are mostly doing, for legal aid, really mostly doing phone assistance. And so our approach is really a lot of kind of light touches, if you will, where we are helping folks with counsel and advice and brief services and not full representation. I think there's lots of different models for us and the size of our state and the amount of need. This has been the best approach. Next slide, please. I just wanted to I have updated financial benefit slides that we are working to update. I didn't make the deadline. Return on investment matters, especially if you are collectively funding a project. This is the kind of financial data we share with our members to really show the value, right? We can tell the story. We have patient stories, which put that into context. We have care team and provider stories, right? Why does it matter to your providers? I think it is a recruitment and a retention tool, medical legal partnership project. But then you can also see in real kind of dollar values, the impact on patients that they both received and how much they would have had to pay to secure legal help. And to be clear, in many of these communities where our patients are getting services through the Health Justice Partnership, there is, even if the patient had a pile of money to get there's not even attorneys in a lot of these places. So it's sometimes both an issue of cost and just an issue of access because of the rurality and the frontier nature of some of these places. Next slide, please. This is another nifty way to look at social needs. But this is a little on the left, which I like, but on the right is really how do we think about care teams and how do we think about integration of the intervention, right? Who is intervening? What is the intervention in response to screening positive for patient level social needs? And which of those interventions are we providing ourselves? Which are we referring for? This is how we kind of include that attorney, the paralegal, and also pro se resources into that broader care team. And then we can go to the last slide. This is my contact information. If you have questions, we're happy to provide more information, the screening tool, talk about the project. Don't hesitate to reach out. That's it for me.
Great. Thank you so much to our three panelists. So today, if we can start. We selected one of our questions and we can go around. First Olivia, then Dr. Andrea Caracostis, and then Palak, in that order. So the question is, what is your vision for the future of SDOH innovation in a healthcare setting? We can start with you, Olivia.
I think I have been thinking a lot lately about, we've been doing a lot of workforce work, and I know I think that as we think about health centers, right, and all of our workforce challenges, we have a lot. We had a lot before COVID, we have a lot after COVID, but the health centers that are really looking to be the employer of choice, and I know that's language that some centers really use. So I've been thinking, I've been in some of those workforce trainings, and I've been thinking a lot about the role of social needs screening and interventions as a workforce issue, both for the workforce that provides that service, but people have a lot of choice in where they are working in our communities in Montana these days, and what makes health centers different, I think, is this piece. So I think it's exciting to think about it in a workforce space, and I also think that social needs need to be integrated across. It needs to not just live like this is the SDOH zone, right, and the rest of everything else we're talking about. It needs to be integrated in every other conversation that we're having. And so I think it's been a really powerful conversation with workforce lately. That is the vision and the future that I have been thinking about and kind of evolving in my brain as of late.
That is great. That is great. So we can move forward with Dr. Andrea. What is your vision for the future of SDOH innovation in a healthcare setting?
Yeah, I think the future to me is really looking upstream and making long-term changes. I think referrals are fantastic. I think that making strategic partnership is really critical. And I'm on the same wavelength with Olivia. I think, workforce is definitely a really important one, because I believe that everybody is as healthy as their pocketbook. So we have to create those opportunities for community development and community enrichment.
Love that. And same question for you, Palak.
Yeah, I think I echo both everybody's saying. I think workforce, and then being able to support that workforce with reimbursable opportunities for sure as well, to kind of grow and cement the growth. I think SDOH in the health center setting aligns with policy advocacy as well, which means upstream, as Andrea was saying, that we have to look and focus as to what can we do to look at long-term sustainable changes. But I also think, like, in a lot of ways, and not just social determinants of health overall, there will be some combination of understanding the role of technology, and as we look at AI and how it's evolving, with how important that human connection and network is in healthcare as well. So I think social determinants of health will be in a very similar space, where we would be looking at innovations in technology to support the human element of providing health and social needs.
Thank you so much. We want to thank you also for your great presentations. And we want to remind our attendees that you'll be getting access to the materials today, together with the contact information of our three awesome panelists. Without further ado, I'm going to pass it on to my colleague, Hansel, who will be talking about some important resources for today.
Yes. Before I do talk about those resources, thank you to the three speakers for joining us today and sharing their knowledge with all of us. It is great to hear all the innovative work that health centers, PCAs, and other organizations are doing to gather that SDOH data and use that SDOH data to keep on improving the resources and the services that you guys offer to the community. So one more time, thank you for doing that. We have some resources that we wanted to go ahead and share with everyone. The first portion of the resources are all toolkits and reports. And then the second portion is going to be some videos. So these are all tools that some of our organizations, some of our partners that make up the SDOH Academy put up together, either because they are resources that they created themselves, or because these are resources that they felt would be useful for you guys when it comes to SDOH data gathering and utilizing that. Next section, next slide, please. All right, so at this moment, we're going to go ahead and ask that you guys take some time to complete the survey for today's session. We want to hear from you all, and we want to know how we did and what we could have done differently. Through this survey, we are able to gauge the success of our session. So it shouldn't take long for you to answer that survey. We ask that you go ahead and complete it for us. It should have been dropped on the chat box If not, either way, it will be included on the follow-up email. But I ask you one more time to go ahead and complete that survey for us. It is very useful. We do look into that information, and that's what we use to cater to go ahead and create content for the following years. Next slide, please. And with that, we've come to the end of our presentation. So if you have any questions, if you want to go ahead and reach out to any of our speakers, if you want to reach out to any of the organizations that appeared in the beginning, feel free to visit our website. Another friendly reminder, the slides and the recording will be made available. So for those that are still wondering, will I get the slides? How can I get the slides? How can I go about that? We will be sending them, they will be made available on our website. We've put our website in the chat box, but we'll go ahead and put it one more time for those that might not have had the opportunity to grab that. So if you have any questions, if you want to learn more about what SDOH is doing, the Academy, feel free to visit our website. And this concludes part 2 of our webinar series. On behalf of the SDOH Academy, I wish you all a great rest of your day.